Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialyse Transplantation, Marcus at Home welcomes Professor Stephen Nicholls in Melbourne, Victoria, Australia, with whom we would like to discuss cardiovascular safety and efficacy of the dual incretin agonist Tirzepatide compared to GLP-1 agonists, focusing upon his SURPASS-CVOT study. Dear Stephen, it's an honor and a pleasure for us to have you back at home after our 25 discussion on CETP inhibitors.
It's great to be back. Thanks for the kind invitation.
Professor Nicholls is director of the Victorian Heart Institute in Melbourne, and I think he's one of the most distinguished scientists at the moment, great trialist, and has been involved in some very major cardiovascular outcome trials that of key interest in the field, particularly also lipid biology. He's professor of cardiology at the University of Adelaide and consultant cardiologist at the Royal Adelaide Hospital, principal research fellow of the National Health and Medical Research Council of Australia. And well, we're very, as we said, very happy and honored to have you here. Looking forward to your presentation, Steve.
Thank you. So at the European Diabetes meeting in September last year, we had the opportunity to present the results of the SURPASS cardiovascular outcome trial. It was the first cardiovascular evaluation of Tirzepatide, the dual incretin agonist. And importantly, it was the first active comparator cardiovascular outcome trial in the diabetes space. And so the question that we wanted to ask, would dual incretin receptor agonism surpass existing GLP-1 receptor agonists? This slide summarizes my disclosures. We've got extensive evidence now from a number of clinical trials showing us that GLP-1 receptor agonists have important cardioprotective effects in high-risk patients with type 2 diabetes. We've seen those benefits subsequently extended to a range of other clinical settings. We see benefits in the setting of obesity, overweight, people with chronic kidney disease, and we've now seen benefits beyond atherosclerotic events looking at particular heart failure with preserved ejection fraction. Tirzepatide is a dual GLP-1, GIP receptor agonist. In theory, there are some complementary effects on top of just GLP-1 receptor monotherapy. And in theory, that should translate to greater biochemical effects. We see in early studies, Tirzepatide produces greater reductions in HbA1c, greater reductions in body weight compared to a GLP-1 receptor agonist by itself, greater benefits in atherogenic lipid factors, blood pressure. And so that led us to SURPASS-CVOT, a study of patients who were at least 40 who had type 2 diabetes, established ASCVD, had an HbA1c between 7 and 10.5%, body mass index of at least 25. Patients were randomized in a one-to-one fashion to receive weekly injections of either Dulaglutide at the 1.5 milligram dose, and we can talk a little bit about that later on, or Tirzepatide, which was dose escalated to a maximally tolerated dose of up to 15 milligrams per week. There was a cardiovascular outcome trial. The primary endpoint was cardiovascular death, MI, and stroke. And this was primarily set up as a non-inferiority study. If we could establish non-inferiority, then we'd go on and test for superiority of Tirzepatide compared to Dulaglutide. What did we find in this study? We found greater reductions in HbA1c and body weight, as we had seen in previous studies for Tirzepatide compared to Dulaglutide. This is the primary endpoint of the study, the 3-point endpoint, cardiovascular death, MI, and stroke. We met the criteria for non-inferiority. We then went on to test for superiority. We observed a hazard ratio for the comparison of 0.92, upper confidence interval 1.01. So just failed to meet statistical significance for superiority. When we looked at key secondary efficacy outcomes, we see very similar effects, non-inferiority for MI, stroke, cardiovascular death. When you look at a slightly more expanded MACE endpoint that includes coronary vascularization, there were less of those events in the Tirzepatide versus Dulaglutide group. And importantly, there were less patients who died for any reason in the Tirzepatide group compared with Dulaglutide. We also pre-specified that we looked at the change in eGFR from baseline to 36 months in those individuals who had high-risk CKD. At baseline, we see less of a reduction in eGFR in the tirzepatide-treated patients compared to dulaglutide. This looks at the fatal outcomes in a little bit more detail. You see the event curves for all-cause mortality on the left. They begin to separate about 6 months in, and we see a significant reduction in non-cardiovascular death in the patients treated with tirzepatide. Now, dulaglutide had been previously studied in a placebo-controlled trial called REWIND. That had established the cardiovascular efficacy of REWIND. It gave us the rationale for the active comparator study. But what we also did was we pre-specified that we would do an indirect comparison to the placebo patients in REWIND who would have met the eligibility criteria for SURPASS. And so this just gives you a sense for what the placebo comparator effects of tirzepatide would have been. You can see for the primary endpoint, it would have been a hazard ratio of 0.72, or the expanded MACE 0.8, for cardiovascular death 0.75, all-cause mortality 0.61, and the combination of cardiovascular death and heart failure events 0.7. When we looked at that composite primary endpoint, you see the benefit in the overall population on the left, in that high-risk CKD population on the right. It is predominantly driven by patients being less likely to have a persistent reduction in eGFR of at least 50% compared to baseline. When we looked at safety and tolerability, we observed no difference between the groups in terms of adverse events and drug discontinuation. We did observe more patients treated with tirzepatide experienced GI side effects. This was very consistent with previous studies and was actually very predictable. So this really provides an evolving landscape of clinical benefits with tirzepatide. We now have multiple reports tirzepatide having benefits in patients with obstructive sleep apnea, in the setting of metabolic dysfunction-associated steatohepatitis, and again, like we've seen with semaglutide, in the setting of heart failure with preserved ejection fraction and obesity. There is an ongoing outcome trial of tirzepatide. It's called SURMOUNT-MIMO. This is very similar to the SELECT study, 15,000 patients, high cardiovascular risk, high BMI, but no type 2 diabetes. And that, unlike SURPASS, is a placebo-controlled trial of tirzepatide versus placebo. That's ongoing, and we wait to see the results of that study. So in summary, tirzepatide is a dual GIP/GLP-1 receptor agonist with favorable effects on a range of metabolic risk factors. SURPASS-CVOT demonstrated that tirzepatide was non-inferior to the dulaglutide for the composite of cardiovascular death, MI, and stroke. Tirzepatide had favorable effects on fatal events, kidney outcomes, and expanded MACE, including coronary vascularization. And this really adds to a setting of clinical benefits of tirzepatide in a range of high-risk cardiometabolic settings. And be happy to looking forward to the discussion and see what you think of the data.
Thank you very much for the short presentation. I have two fundamental questions that come to my mind reading the study results. I believe all patients had a long time diabetes, an average of 14 years, and a relatively high HbA1c. So maybe this suggests that the focus was on high-risk patients. And do you think this also applies to young diabetes patients with a recent diagnosis?
Well, I think it's a great question. I mean, yeah, the baseline diabetes demographics and biochemistry, I guess, is consistent with a lot of these studies. These are people with ASCVD who've had diabetes a long time. Their HbA1c is above 8. They clearly need something else done. We saw a high rate of use of baseline diabetes therapies. And keep in mind that this is a study that started enrolling in 2019, 2020. I think the baseline SGLT2 inhibitor use was about 30%. We saw about 15 to 20% of patients subsequently start one of those agents during the trial. These are really people that we want to be treating more intensively. I'd like to think that that younger cohort with premature events and diabetes, which probably is shorter in duration, we would see similar benefits. We know they are particularly high risk, but a lot of that risk is potentially modifiable.
And the second question, my last one is, we see that 21 persons are still taking at the beginning sulfonylureas. So these are no longer medications we usually see often in Europe. So how is this in the USA or in Australia?
Disappointingly still there, and thank you for that question. It still frustrates many of us in clinical practice that we see these agents which really have no macrovascular benefit, and the microvascular benefits are pretty limited compared to a whole bunch of other and much better alternatives. Unfortunately, these are very cheap agents. A lot of doctors feel very comfortable. They've prescribed them for many years, and it does reflect this kind of inertia that really does creep its way into the clinic. Old habits are hard to change, and we now have really effective agents, SGLT2 inhibitors, GLP-1 receptor agonists. We're now advancing that with tirzepatide and beyond. One can only hope that we're not talking about sulfonylureas in years to come, but we certainly did see some use in this study.
Well, a lot of this is obviously about availability and price, and that differs worldwide. Also about dosage. I mean, we see a lot of patients on dulaglutide because it's actually less expensive here in Germany than tirzepatide. And then the dose, what you alluded very shortly to the fixed 1.5 milligrams in the study. There's a 3 and a 4.5 milligram. And then similar with semaglutide. And that's all about also company and advertisement and these things. And now they go along and do a 2 milligram dose in diabetes. We have a 2.4 milligram in obesity. So what's your thoughts on, do we need a dual or even a triple? Maybe you can say something about that. Agonist or antagonist, these studies are all on their way, or is it just dosage of the substance?
Well, I think there's a few really great questions embedded in that. So
All
first
right.
of all, I mean, access is a big deal in pretty much every country in the world. We used the 1.5 dose of dulaglutide for two reasons. One, it was the available dose when the study was designed. So yes, and we get asked this a lot about SURPASS. Why didn't you use the higher dose? We didn't have the higher doses when we actually designed the study. The 1.5 dose did have benefits in rewind. So actually, it allowed for us to do the comparisons that we were able to embed within the study. This was an active comparator trial, and we were purposeful about that. We didn't think it was right to embark on a study for 5 years, knowing that GLP-1s were going to become increasingly more available. So the best thing to do was to let everybody have a GLP-1, and then half the people got something on top of that. We see at least non-inferiority on hard outcomes, and you see a lot of benefits in terms of metabolic risk factors. Will there potentially be triple and other agents? Yeah, we're seeing them in development today. And I think if we can develop therapies that, for a given patient, favorably modulate their cardiometabolic profile, not just their risk factors, but their events, and can be done in ways that are well tolerated. And we know these agents have GI side effects. We also know that some of the weight loss with these agents comes with muscle loss. And so there's ongoing efforts to develop agents that hopefully preserve the metabolic benefits, but at the same time, some of these other effects we don't see. So that's why it's a really exciting time in this space. There's so much activity. We're delivering this outcome trial, which we think is a pretty good study of a pretty effective therapy. And yet at the same time, there's still a lot of work ongoing with even new therapies, and it's exciting to see where the field may go.
Going further from there would be the next question that kind of fits there is the question for the oral substances. Do you think that's an issue? There is semaglutide out there. I think the tirzepatide is coming onto the market. It's not available in Europe. I think it's going towards there in the US.
I think there are oral combination therapies. Look, the really exciting thing for me with this is patients are going to have choice. You're going to be able to sit in your room with your patient and actually work with them to find the right therapy for them. Some people will want to take an oral, some people will want to take an injectable. If there's access to these things and you can actually sit down with them and say, look, what are you most likely going to be adherent with? What's going to work best for you? Share the decision making. The optimist in me has got to believe that that is going to result in better long-term adherence. And that is one of the big challenges with this field. We already see the reports that if you stop taking these therapies, everybody seems so surprised that you start regaining weight. You're right. And of course you do. And but it really does speak to the concept that these are not quick fixes. These are not short-term therapies. These are long-term therapies that we are really asking our patients to take. And if we can work with a given patient to say what is going to work best for you, then I think that's a really good outcome for us to get to.
As nephrologists, Caro and I surely have, again, to allude to this great data on nephroprotection. And this is also kind of seen in other tirzepatide studies, which have compared tirzepatide to placebo or to insulin. And then surely always comes the question, do we have an idea why tirzepatide might even be better than mono GLP-1 agonists?
Well, to what degree it may reflect the actual mechanism of the drug and to what degree it reflects the improvement in the metabolic kind of profile, I think we don't know the answer to that. I'd really love to see a very large study that's now just exclusively done in the CKD setting, and I'm sure you clearly would like to see that too. We have more data coming out. We did present a deeper dive on the kidney outcomes in Vienna at EASD, and that manuscript will be out soon, which is great. So I think that will give you more information in that space. And then at the ACC in a few weeks, we are presenting an expanded composite outcome. And that will actually include all-cause mortality, the MACE endpoints, but also the renal endpoints. And the reason I raise that is because, we all manage these patients. These patients don't just have heart complications or kidney complications or liver complications. They are at risk of having all of them. And maybe we need to change the way that we're thinking about outcomes in these trials and thinking if we're going to take high-risk patients with type 2 diabetes into big trials, well, maybe we should start evaluating the effects on a broader kind of complex of outcomes. And we look forward to sharing that data in a few weeks' time in New Orleans. It's pretty intriguing.
One more question, which surely cannot be answered by an RCT, which compares two drugs, but which is important in clinical practice. So we are all fascinated by these drugs, and also our patients in the vast majority are fascinated by them because they really kind of gain so much quality of life after losing weight. But the naughty issue surely are the gastrointestinal side effects. And then we always have to ask ourselves, would it be wise in somebody who does not tolerate one of these drugs to switch to another, to say, if you do not tolerate semaglutide, to go for a trial for tirzepatide? Or would you expect that the same patient would see the same side effects, at least at a comparable dosage of the drug?
Yeah, I guess I have a couple of thoughts about that. One, I think it's absolutely worth a trial of other agents. Part of me kind of thinks, well, if you've had them with one, you're certainly more likely to have them with another. But patients don't always have symptoms with other therapies that are related. It does also talk to the importance of really being upfront and managing expectations with patients. Like, if we're going to talk about shared decision making, we do need to talk about what are not uncommon side effects and say, look, there's a reasonable likelihood you're going to get some GI upset. And it might look like this. I was very involved in the SELECT trial. We spent a lot of time in that study, for example, just when we were enrolling patients, really talking to them about both the GI side effects and to not just stop the drug if you didn't think you were losing a lot of weight and just assuming you were on the placebo in that trial. And so those factors do speak to this concept that actually that conversation we have with our patient up front is really important, and then continuing to check in on them. But I would absolutely do what you suggested, which is if I have a patient who has GI upset with one of these therapies, I will certainly at least have a conversation with them about would they be prepared to trial another agent. And quite often they are. Depends a little bit on what the symptoms were and how severe they were.
Thank you. I also have one last question that you sort of went into the direction already, the topic of weight loss, and we're all discussing that all the time. What's in your thoughts, particularly now with the Summit study, the relationship between weight loss and the endpoint reduction? Is it independent? We do see a correlation. You already said that similar to antihypertensives and diabetic and lipid lowering drugs, if you stop the therapy, weight goes back up. What about the endpoints? Would that also, would the curves flatten again? And is there an independent pleiotropic whatsoever effect?
Yeah, I think the mediation analyses and with all of these programs has been pretty limited in what it's shown in terms of weight loss. So, the weight loss just purely by itself doesn't jump out. The second thing I'd say, if you look at the event curves for a study like SELECT, they separated very quickly. They separated well before the weight loss would have been meaningful. That says a lot. I think absolutely if you stop taking these therapies, events will continue to accrue. There is a view whether you treat people intensively from an LDL perspective or you have a period of really intensive metabolic improvement, you're probably resetting somebody to some degree. So while their prospective event rate will increase, it may increase at a lower rate than it was going to before you did all of that. So, and we have these conversations that come up with new therapies, particularly when they come at cost. Is there a possibility in the future to think, do we treat people short term? Do we treat them for a finite period of time and then move back to a less expensive kind of therapeutic regimen? I think there is some argument for why that might not be unreasonable from a lipid perspective. I think if you're dealing with people where you've got overweight, obesity, then we've got to think that there's a whole range of health consequences that come along with that. It's not just about the heart. There's joints, there's, all sorts of other issues. And so I truly believe that I think once you embark on these types of therapies, they really are long-term strategies.
All right. Well, Gunnar, Carolin, if there's no more pressing questions, I'd like to take the opportunity to thank you so much again, Steve, for your time. Particularly, really, truly thank you for your very, very concise and direct and very, for us, extremely useful answers, and also for the listeners and viewers of the channel. So thank you very much indeed for your insights. Hope to see you again in the future with some more great trials. I'm sure we will. Would be happy to see you again on this channel. So thank you.
Always happy to chat, and always appreciate the robust discussion. It's a really active time, which is great.